Well, this is going to be so exhilarating, you won't remember you ate lunch. All right. Well, thank you all for joining this very important topic. If you see me looking at my phone, it's because all of my questions are here. So I'm not on TikTok or anything like that, so I'm not disengaged. I'm totally here. All right. But we have this, we have the distinct privilege of really discussing what I feel is a very important topic around using real-world evidence to address health disparities. Obviously, we know that that health disparities is a very, very, very broad concept and issue. So we're going to narrowly focus this a bit more on the clinical research aspects of health disparities, so clinical trial diversity and all the other issues that go into clinical research. And so I'm joined with a very distinguished panel. So I want to provide brief intros on each. You'll hear and learn a lot more about each of these individuals and the important work they're doing throughout the course of the questions that we'll ask. We will make sure that we have that we reserve some time at the end for questions and all of that. So don't feel like you won't get an opportunity to do that. Can you all hear me okay? All right, good. All right, so first I'm joined by, to my immediate left, I have Dr. Robert Hiatt, who is a professor and former chair of the Department of Epidemiology and Biostatistics at UCSF and the associate director for population sciences at the UCSF Helen Diller Family Comprehensive Cancer Center. He is also the principal investigator of the NIH All of Us Precision Medicine Initiative at UCSF. Next to him, to his immediate left, we have Dr. Alice Popejoy, who is an assistant professor of the Department of Public Health Sciences within the Division of Epidemiology at University of California, Davis Health. She also leads the Public Health Genomics Lab at UC Davis Health, which operates at the intersections of computational genomics, human population genetics, clinical genetics, biomedical data science, and bioethics. Interesting enough, and you'll hear more about this, her current research is focused on investigating diversity measures such as race, ethnicity, and ancestry in genomics and medicine, with the goal of developing standards, recommendations, and novel computational approaches to modeling human population diversity. To her immediate left, we have Abasi Ene-Obong, is that right?
Correct. Yeah.
All right, who is the founder of 54Gene. He is a seasoned business leader with extensive experience in the US, UK, and Nigerian healthcare industries. Among his other notable mentions, he's also recognized as one of Africa's young innovators, one of Fortune's 40 under 40 most influential people in healthcare, and as a Bloomberg catalyst in recognition of his contributions towards accelerating solutions to global health problems. He'll explain more about 54Gene and what their purpose is throughout the course of these questions as well. And last but certainly not least, to his immediate left, we have Dr. Vic Spain, who is the Global Real-World Data Lead of Hematology and Respiratory at Genentech. His role includes identifying and evaluating new or evolving data sources from routine clinical practice that can inform strategic decisions in Genentech's development programs. Welcome, you all. It is a pleasure to be in. Oh, well, yeah, please. The stakes are high. They've given you a round of applause, and if you don't get any more, then that means that we didn't do very well. Yeah. So get yourself ready for that. All right. So my first question is going to go directly to. Well, first of all, let me say this. I don't know if you guys saw. There was an important tweet that came out last week from Dr. Califf around the whole clinical research enterprise. And I don't know if you saw it, but I'll read it to you really quickly. Basically, he said there's a major reformation of our national system for generating medical evidence. Our clinical research system is too slow and expensive, leading to a vast gap between what we need to know about health interventions and what we actually know. He then goes into talking about the lack of representation in the trials as being a critical issue for how we think about clinical research, which sort of brings me now to my first question to Dr. Hiatt. What are the biggest challenges in this whole health disparities, and how do you think digital technologies and real-world evidence can ultimately address some of these challenges?
Thank you for that small question.
All right.
Right.
That's what I'm here for.
Right. So let me first say that I think the whole challenge of dealing with what's called disparities is very complex and very challenging, but very important. I think if you look around the world, there are differences in all populations with subgroups, no matter where you are. And the differences between them are a challenge to us scientifically to understand how to address them and understand the reasons for them. But there's also a social justice issue that's very important. So the way I think about the word disparities is more like an inequity. When we really want to understand differences, we want to understand inequities in different subpopulations. And the reason we're concerned about it is because these inequities are, by definition, unfair, unjust, and avoidable. So if we discover what's behind an inequity, and we can do something about it, then we can provide therapies and prevention strategies for a broader section of the population. So to answer your question, the importance of disparities, I think, is to understand the reasons for these differences, to understand how best to approach them for both treatment and prevention, and to understand these differences will, I think, help reach a more equitable society in general.
Anyone else have anything to add to that? Well, so which in light of what you just said, it brings me to my question for you, Alice. You've been investigating diversity measures such as race, ethnicity, and ancestry in genomics and medicine. What is your perspective on the existing categorization of these minority groups, and how would you define inclusion, and how would we track it? It's a very loaded question.
Yeah, thank you for that. When we talk about diversity measures like race, ethnicity, ancestry, and we categorize people according to these discrete measures, first of all, we have to define where we're getting these categories from. We actually, one of the investigations we did in ClinGen, the Clinical Genome Resource, was to look at clinical lab requisition forms and all the categories that were on them. And of the top 10 ClinVar submitting labs, no two forms were the same in terms of the categories that they offered. So there's no standardization, there's no harmonization, and that's just sort of the technical, logistical, overarching problem. But if you go back to sort of the history and the philosophy of human categorization, it's really old. And it has traditionally been done in order to marginalize certain groups of people relative to others, to sort of create and preserve hierarchical power structures and consolidate resources, and to justify oppression, colonization, extraction of resources, genocide, and slavery. So the practice of categorizing human beings into discrete labels, particularly with something as loaded as sort of origin or something like a population, it has a lot of downstream implications for the research results that we have, the way we do our analyses, and I think if we don't sort of address the underlying philosophy first and the history of categorization itself, we just sort of run around in circles asking ourselves which categories should we put on our requisition forms, and the answer is always different because people have different opinions, and when there's a sort of missing underlying scientific and conceptual validity to a measurement system, you're not going to achieve standardization because there's a different type of information that you need for different types of questions. So I guess, in terms of what I think about the current categorization practice, I understand the need to have some way of having harmonized, standardized measurement for tracking something like equity and inclusion, which is the second part of your question. And so, of course, in the United States, we use the Office of Management and Budget categories for the census, which change every 10 years roughly, but that's used for policy and resource allocation, things like that. So that's important, but I think in terms of inclusion, we have to think more broadly than just race and ethnicity categories. And in terms of defining inclusion, I think it's not enough to just look at who's in our research study and say we need to get more people of different races and ethnicities. Inclusion efforts, I think, have to be an active effort to reach people who've been traditionally marginalized and excluded from our systems and structures.
Very good. Abasi, you want to chime in?
Yeah. Is this working?
Yeah, it's working.
Yeah, so I think what Alice you're saying is that the definitions we use are not representative. And I totally agree with that. And I think what it means is that we need to find better ways to kind of categorize people in the clinics, etc. I remember as a student in 2008 and a genetic student studying the HapMap project, my teacher in London told me that the Yorubas represented all Africans. And that was the understanding back then. One ethnic group represented me who wasn't Yoruba. And I knew just from being told that was wrong, because growing up in Nigeria, I didn't speak the language, I didn't think we shared the same ancestry, and I didn't see how we could be represented by a group that lives on another part of Nigeria from where I lived. And I think that today, and with the work we're even doing at 54Gene and in other places, we're seeing that there are differences. And these differences matter clinically. We are seeing differences in pharmacogenetics within country, within Nigeria, for example, when you look at different ethno-linguistic groups. We're seeing differences in variants. We're seeing new variants pop up in ethno-linguistic groups that haven't been sequenced before, that we are sequencing. And I think the question then becomes, is it enough to categorize somebody as Black African? Because no, it's not enough. Genetically, yes, I am Black African, but I might come from a totally separate ancestral lineage that's different from the next Black African. And if you categorize us as that, you may give me an intervention that doesn't work for me, right? And so I think that we have to get more granular in the precision medicine space.
So tell me, what exactly is your company doing to sort of address that particular issue?
Yeah, so, I started 54Gene in 2019, and the goal was really to bring the, let's call it the beauty and complexity of African genomics to the to global practice, and to use that to inform how Africans receive healthcare, but also how people from all over the world receive healthcare. We all originated in Africa, and Africa is one of those continents with a very high degree of genetic variation. And I kind of believe that if you want to really do precision medicine today, you have to go to those parts of the world where you see the diversity in human beings, right? Because that's where you see the things you don't see in other places. And so, in going to this beautiful continent of 1.4 billion people, 2,000 ethno-linguistic groups, 54 countries, complex environment, but genetically very beautiful. And so we set up to begin to build genetic resources on the continent of Africa, whether that means putting in sequencing labs that allow for some of the work to be done there, biobanks that allow for capture of different diseases, as well as clinical information attached to those samples. And that's what we do at 54Gene, and using that to either look at new variants that we can target from a drug discovery purpose, or how do you improve diagnostics as a result of these new variants we see.
Impressive. Vic, so from a pharma company's perspective, what do you see as some of the bigger barriers and enablers to the recruitment of these diverse patients in light of what you heard from Allison and also what you heard from Abasi?
Yeah, let me first add on to something that Alice mentioned about the categorizations. My mic okay?
Yeah.
Yeah. Okay. Great.
Yeah, I can-
So even as Alice mentioned, there are limitations to these categories that we have to work with from OMB. But even if we were to accept them at face value as being useful, we run into some really important data quality concerns. So as an example, I like to tell the story of the last time I went in for an X-ray. The person registering for me looked at me and checked off the box for race and ethnicity that they thought I was, based on what I looked like. In that particular case, they were correct. They guessed correctly. But we don't want to rely on that in our data sources, of course, right? And what we're seeing when we compare the race and ethnicity that's in a patient's medical record as compared to what we believe is their genetic ancestry, one of the biggest sources of errors is identifying patients of Hispanic or Latino ancestry. And we don't believe that people don't know that they're Hispanic or Latino. It's just that information doesn't get into the medical record. And so it creates a huge barrier for us. So that would be a challenge if there are data vendors, clinicians here, of one way we can improve data quality. But to address your question on barriers more broadly, I'll put them into a couple categories. As we know, our clinical trials can do better. Traditionally, we've not done a great job of really getting a trial population that's representative of the true underlying patient population and understanding differences. Whether you want to call it precision medicine or heterogeneity of treatment effects, that's the term I usually use, or personalized healthcare. We just don't get that as reliably out of our clinical trials as we should. Okay. Sorry about that. And so there are a couple of barriers. The logistic barriers. We traditionally targeted very particular kinds of sites for our clinical trials, and those may not be the places where patients decide to get their health care. If you live in North Philly, you may not want to travel to Center City, Philadelphia to get your health care where the clinical trial site is. So I think some pharma companies are really branching out in that way. There's recruitments to barriers. As we know, there's a lot of long history of trust in the system that we have to address. One area where I've really liked to focus is on actually how we design our trials. We often are faced with inclusion and exclusion criteria that inadvertently keep certain patients from enrolling in the trial. So as an example, the first asthma trial that I supported, you couldn't be in the trial if you were HIV positive, if you had hepatitis C, if you had poorly controlled diabetes, if you had been in the hospital for congestive heart failure. And these are all conditions that we know disproportionately affect people of certain races and ethnicities, gender identity, sexual orientation, et cetera. And so those people were off the bat ineligible for our trials. And I'm glad to see that we've actually made some progress on this. One of our trials we launched recently, we removed the HIV, we removed the hepatitis C, we removed some of these criteria that we don't need these anymore. These patients can still complete our trials successfully, they can still come in for their visits, so we really don't need those anymore. So that's an important step that I think we're taking to address that.
Do you see, because you mentioned something that sort of resonates with me around the whole Philadelphia story that you gave, Central versus North. And there's obviously concerted efforts to extend the site network for many of the pharma companies. And then you also see this rise of, non-traditional CROs in your CVS's and your Walgreens and all these other places. What's your perspective on the role and sort of the reimagination of the role of the CRO in many of the clinical trials and how that impacts sort of diverse representation in trials?
Right. That's a great point. So, I guess there are a couple pieces to your question. One is, as I started to mention a minute ago, actually making sure we know where the patients want to reach are and where they're getting their care, and making sure we're going to where they are. Part of it is improving our recruitment methods. We hear anecdotally a nurse will say, "Oh, this patient might qualify for a trial, but she's a single mom. She has to take off work to get into the office. She has to get child care. I don't think she can handle a clinical trial." So really thinking about how do we make it easier for patients to participate, non-traditional patients to participate? How do we address these really hands-on logistical barriers? And I think certainly I see a role for CROs in helping new sites that maybe aren't used to addressing these barriers to train them, get them up to speed on how they can best address this.
That's great. Abasi, so I'm thinking about what Vic just said, and I also think about the fact that there is a considerable amount of investments going into companies such as yours. I mean, no offense, but they're in precision medicine, decentralized trial companies, virtual trial companies, RWE companies. There's a lot of money going into these places. What sort of excites you about that, and what gives you pause about it?
So I'm pausing.
You can be biased, it's fine.
Okay, so, yes, I see that there's a lot of money going into this space, but it's actually biased towards, Western companies, US mostly, and then, of course,
And you see
Europe.
that as an issue, that gives you pause.
Yeah, it does give me pause, right? Because I see the value of, as the world gets more globalized and as we begin to think more about, healthcare, not just from an American perspective, for example, but a global healthcare perspective, and as the US itself gets more globalized, right, the demographics are changing, right? And how do you solve healthcare in the US amidst a changing demographic when you're not going to those places where you have those people, And so, I worry that sometimes we might spend a lot of time doing things in places that we are comfortable doing them in, and we lose a lot of opportunity in going to the places where we find actual new information. So I don't know if it's...
No, that's a very
Yeah.
interesting point. So what I'm hearing you say is that there is sort of, we're following the very traditional approach of sort of over-indexing on Western-based or US, UK-based companies, and we're not sort of mobilizing or investing in those companies that are really addressing, from a global perspective, underserved populations and communities.
Yeah.
Go ahead, Alice.
Yeah, I just
Okay.
wanted to amplify what you were saying about the importance of investing in companies that are doing research outside of the US and the UK, and particularly because of this problem of the overrepresentation of European ancestries in research in the US and the UK. And I think also you're sort of modestly understating the importance of genomic diversity in Africa specifically as the ancestral homeland of the entire species. Often you see these depictions of out of Africa events, and then there's sort of this like evolution as if somehow genomes in Africa have not also continued to evolve since the out of Africa migrations, right? So you have these ancient lineages, ancient genome variation that have smaller haplotype blocks, smaller LD blocks, more variation, a lot more to teach us about genetic heterogeneity of diseases. So I think the value of genomic data from African countries in particular relative to everywhere else in the world is so disproportionate that it's really unjustifiable that we're not investing as proportionally in these regions.
She said it all. Thank you.
Go ahead.
So I'd like to elevate a comment that was made in the last session, actually, by Dr. Mindy DeRuin. She was asked a similar question about how...
Oh, I didn't take it from her. I didn't go to that session.
No, you're good. No, the question to her was, how does she categorize individuals in epidemiologic studies? And she made a clear and I think very important point that of the two ways, self-reported race and ethnicity and ancestral informative markers or some other genetic categorization, both of them are important. And you don't try to mix them because they tell you different things. And it's based on the research question. If you want to know something about individuals' habits, environment, behaviors, then self-reported race and ethnicity is the important thing to use. If you want to know something about how somebody responds to a particular drug or something that's more biologically based, then a genomic categorization may be more appropriate. But it's not one or the other, it's both, but they both have value. And I thought she made that point really clearly. I don't know how many people here were at that previous session, but I just wanted to emphasize.
You got some heads nodding, so
Yeah.
people agree.
Yeah.
They're like, she's raising the roof. All right, so along those lines, you being a PI for NIH, it's All of Us, which I think many of us have heard about, at least I'm assuming most people are familiar with. I don't think that we all are sort of up to speed on what the successes and failures, and I just don't, me personally, I have no visibility
Yeah.
into that. So, I mean, can you describe
Sure.
what's going on with it?
So I'm the principal investigator for the All of Us program at UCSF. The All of Us program is a short name for the NIH Precision Medicine Initiative that was started by President Obama. And the goal is to recruit 1 million people nationwide to reflect the diversity of the country and to make data available to both researchers and the people who are participating as we go. So things were slowed down a bit because of the COVID epidemic and inability to sort of get to people in communities, but it has continued, and we're up to about 500,000 participants at this point, and a fairly large number at my own institution, 4,000 individuals. So the good news is that not only are the numbers large, but about 50% of this cohort is part of traditionally race, ethnic categorized individuals, 50%. And about 80% are from underrepresented and biomedical research groups. This means LGBT populations, disabled populations, people from rural areas, and so forth. So what All of Us is doing is collecting real-world data from individuals and linkages, as you heard in the last session, to other data from registries and administrative data, also wearables, and multiple questionnaires. A lot of data is coming in. So, and this data is currently available. You can just click on allofusresearch.org now, and you'll get an idea about the numbers and the basic demographic distribution. Access to the data, I could go on. Chris, stop me when I'm going too far.
I guess I'm curious. How do you so you got this sort of racial, and you have this diversity, diverse representation in your program. Is that by design? And if so, what did you do to sort of recruit this diverse?
It's absolutely by design. So the problem has been said many times here and elsewhere with large epidemiologic studies and other databases that they're primarily white. And you can't make conclusions from a selected population volunteer like that as well as you can if you have sizable representation from other subpopulations. So it was set out to do that. I mean, it was meant to be a very quote-unquote diverse group of participants. It has turned out to be that way so far, and we're halfway through. And the data is available for people to start using. We're doing whole genome sequencing as well as physical examinations and collecting blood for laboratory studies and biomarkers. So there's a lot of information in there. And for me, just thinking about the topic that we're dealing with at this meeting, it's a sort of a combination of real-world data and traditional epidemiology. So the standardization of data comes from the fact that all around the country, no matter where people are being recruited, they're filling out the same questionnaires, they're getting tested in the same way. All the blood goes to Mayo Clinic where it's being analyzed in exactly the same way. All the data is being cleaned and curated at Vanderbilt in exactly the same way. So there's a lot of standardization going on to make it comparable across the country. But still, because we have electronic health record data as well, I forgot to mention that before, we're collecting real world data in people's experience so that we have the opportunity to combine what we collect from standard approaches with information that's happening to individuals over time as a result of their clinical care. So things
Can I ask you something
things
about
are
that?
going well.
No. So it makes me think, though. This is the one thing about the real-world data, from my vantage point, that we struggle. And we used to call it 2 decades ago, the digital divide. I think it's more of a data divide. And there's sort of a underrepresented population that's not captured in many of our data sets, either because they are not receiving any care in the systems that currently exist, meaning many of your rural populations, or even folks that are from me, like I'm from the southern sector of Dallas, Texas, right, originally. Many of my family members, I can guarantee you, have not been in a hospital to where they don't have, and it doesn't mean they're in good health. And so when I think about sort of diverse representation in something like All of Us, how are we reaching these sort of folks in these remote areas or in these underserved areas who are not captured in these EHR platforms?
We are reaching out, as the phrase goes, to rural areas, to places that are not not served. We're educating individuals about digital access, making it as easy as we possibly can. We have community connections, community engaged connections, where the individuals who are going into the community represent the populations we're trying to reach. And this whole area of recruitment, at least observational studies, is based, I think, for randomized trials as well, is based on trust. You have to have the trust of the individuals who you want to be part of the project, and it has to be a non-transactional type of relationship. That is, you're not just getting something from somebody and giving them an incentive. They're part of the process. So this is what's called community engagement. And it's an obligation, I think, of researchers who are interested in improving the diversity of their samples to engage in a partnership, equal, co-directing type of way for research projects, which isn't something we do very often.
We, now you brought up another question I have, and I actually was jotting this down. You know, and now we're getting into sort of the social determinants issue. So this is going to be for any of you. Over the past several years, we've seen social determinants of health become more of a prominent issue. It's actually playing into many of the coverage and reimbursement decisions from our payers, to the point where many pharma companies like Vic's and even my own are sort of providing sort of these ancillary services with trials to sort of address that particular issue. I guess my question for you all is, do you see social determinants of health playing any role in achieving more diversity in clinical trials and having that diverse representation? And what are some other aspects beyond sort of food security or food deserts and transportation that we're not thinking about when we think about social determinants issues? That's for any of you.
I can speak to that, but maybe somebody else would like to go first.
Go ahead.
So I think it's very important.
Okay.
As has been observed, the way disease works in populations, it's usually the people at the bottom of the ladder who have the worst outcome. Doesn't matter what it is, cancer, heart disease, COVID, people who do not have wealth, privilege, power, social connections do the worst. And until we deal with those high-level issues face on, we're going to just continue to see disparities and inequity in outcomes. So that's the problem. And so I think it is important to try to understand how to measure social determinants. And I'll say that the All of Us program has a whole module on social determinants measures, not only food insecurity and housing insecurity and racial discrimination, but also social isolation, religiosity, social support, etc. So these are all available for people to study relative to more traditional biologic and physical measures. So personally, I think it's very important to study these things and understand how social factors, the phrase is, get under the skin. So how does exposure to racism get under the skin? What's the biology there? That's the challenge, I think.
And you're collecting that as part of the All of Us program.
Right.
Alice.
Completely agree, and I think social determinants of health are crucial to being able to understand actually what is going on with complex disease etiology. I think we use race, ethnicity, and other sort of very simplistic measures to categorize people as a proxy for deeper mechanisms that are at play in the social, cultural, and economic spheres. And so in some ways, it's a little bit of a distraction, I think, to even start looking at the genetics of complex disease like polygenic risk scores. And then we find these associations and people are like, wow, we can explain all this variation in complex traits. But as you just heard from the PI of all of us at UCSF, the majority of these disparities are completely due to social determinants. And if we are not observing the causal the root causes of those disparities, and all we have is these proxy measures like race and ethnicity, that's all we're going to see. And we're going to continue reporting on the differences by race and ethnicity and continue seeding the belief that there's some biological boogeyman hiding in the genome that's creating these disparities, and it's on the ancestral haplotypes. No, right? These are, these are social, cultural, systemic issues, and there are very powerful interests, sort of vested interests in keeping the status quo at these levels of categorization, because then we are not obligated to begin addressing the underlying issues. And it's been said, I forget who originally said it, but it's cited a lot, that all policy is health policy. Because where people can live, as you mentioned, food deserts, right? Like what people have access to is everything in terms of their underlying ability to live a healthy life. And so I think we have to look at social determinants in order to wean ourselves off of this reliance on imprecise and unscientific proxy measures that cause real harm.
That's a tweetable quote. All policy is health policy. Put that out there. Attribute it to her so I can steal it.
No, don't attribute it to me. I'm pretty sure many people have said it before me.
So Abasi, let me think about this. So if I, at the end of the day, we're talking about building sort of global research infrastructures, right? And you alluded to the fact that there's such a lack of investment in the continent of Africa. And we're talking about this issue of social determinants, which is pretty much relegated to sort of the Western world. But if I were addressing the social determinants of health in a continent like Africa, what would those things be, and what would I need to actually measure and track?
Well, I think we're still trying to fully understand and how to interpret it. But the way we've approached this is by having studies in rural and in urban areas. So, for example, we have studies that we run in communities where we go into homes and recruit in homes, and we capture information related to social determinants of health, so education, religion, and all that type of stuff. To be honest, we haven't yet done the analysis. We have this data, but we haven't yet looked into how the social determinants of health in the context of Africa might influence certain diseases we see. But it's really looking at it from a urban area and rural area, and looking at some of the behavioral traits or cultures in some of those areas, and capturing as much of those as we can. And I guess the challenge then will be, how do you interpret that into like a global normalization? And I don't know if anyone, I'm not really in the social determinants of health side of things, but I don't know if we've actually looked at how do you go into certain geographies, understand that, and then have a normalized way of looking at it across multiple geographies and cultures and issues.
I think that's anthropology.
Well, that's a good point. Another quotable tweet from Alice. But I think it's interesting because we have this tendency to sort of extrapolate our own understanding based on the U.S. Societal norms onto other emerging markets, right? So what we understand to be social determinants of health in the U.S., we may want to project out onto Africa. And you're saying, well, none of that really applies. Does tribal affiliation factor in as a social determinant in Africa, in your mind?
Yeah, so it definitely does, because, when you look at different tribes, there's different customs and cultures that have existed for long. There's practices around consanguinity, around mutilations to the body, around, you can't take these drugs, you can't take pharmaceutical products, you have to take plants. There's all those religious and cultural norms, even amongst tribes, that kind of factor into how you look at it. But when you look at something like food deserts, for example, in the US, how do you extrapolate that in Africa?
Yeah.
What's a food desert in Africa?
Yeah.
Is an urban area of a food desert, in Africa, and compared to US standard. And so I guess those are also other things that we kind of have to look at here.
Go ahead, Robert.
I think the thing that's the same around the world to the human condition is that there are hierarchies, no matter how you measure it.
Yeah.
I'm sure there's hierarchies in Nigeria.
Of course.
And there's differences by tribe in the United States. Appalachia compared to the Northwest, to the Indian tribes of the Southwest, to Boston. We get huge differences depending upon which tribe we're from.
Yeah.
So human society is characterized by differences, and these differences have characteristic behaviors, anthropologists, and maybe differences in biologic or genetic makeup that we need to understand. So it's not either or, in my view. I think our challenge this century is what Dr. Dazu has described as confluence, or no, it's E.O. Wilson, confluence. So it's the challenge of understanding health and human existence from cells to society. So some of us work at the cellular or genetic level, some of us work at the clinical level, some of us work at the societal level, but the integration of all those different disciplines and levels of inquiry, I think, is where the challenge is going to be in the next world. If we're going to be precise about our health, if we're going to follow precision health, then we have to take all these levels into account, in my view.
You mentioned something earlier, Dr. Hiatt, around this issue of trust, which I think I'm glad to hear more people using it. I think that how we define it could be different. But let's just say there's historical challenges with the issue of mistrust in the system from certain populations, Black people, Black Americans specifically included. Does the whole decentralized trial movement sort of distract, to use Alice's earlier word, from this issue of addressing the mistrust in the system? Because there's no data that's going to really, I don't even know how we would even measure and capture that, right? With this issue of trust. And what's your thoughts about this decentralized virtual trial movement and still this ongoing issue of mistrust in the system?
I think I'd have to generalize and say that I think trust between individuals who are inquiring about the nature of the world, health researchers, and the population who stands to benefit and participate in it is important across the board. So we just had an experience with COVID in Oakland, California, where they weren't getting vaccinated, they weren't getting tested until a group of individuals, Black individuals from the university, went into those communities in a trusted relationship, and the response was tremendous. So it just turned the tables.
So people that look like them going into the community?
In this case, yes. But basically, I think it's trust.
Okay. Go ahead, Alice.
So, I've been working for several years, both my postdoc at Stanford and at UC Davis, in sort of this trying to integrate community engagement into my work, and was fortunate enough to be able to attend and then be a liaison for the American Indian Alaska Native Community Action Board in San Jose. And it was very clear that the issues of mistrust are due to direct harms to people and their communities. And so if you cause harm to someone in your personal life, typically the way to make a repair and to rebuild trust is to apologize and to acknowledge what's happened. So I think first and foremost, before we can talk about trust at all, we have to think about the ways in which we as a biomedical research enterprise, as institutions that have been complicit or the direct actors in causing harm in these communities, what are the ways in which we can recognize, acknowledge, and then apologize or repair for what has happened. I think one of the ways to do that would be to ensure universal access to healthcare, because then we level the playing field, but sort of to do these like common sense universal policies that will help everybody, everyone, and use as a justification for that, these historical harms that have created disparities to begin with. But then I also think we need to shift our focus from receiving trust to both giving trust and to being trustworthy as researchers. So, so often I work with clinical geneticists and a lot of clinical care practitioners tend to have very strong feelings about what's best for their patients. And I think we often will disregard, we mentioned earlier, a clinical trial participation. Oh, well, that person's a single parent. Maybe they don't have the ability to participate in a clinical trial. We should probably still ask that person anyway and trust that they know best whether they have the capacity to participate in that trial or not. And so I think part of the shift is trusting patients and research participants that they're the experts on their own lives and on their identities, and being able to just really hear what they have to say and track that as data, not just as something anecdotal that we have to go through the motions and listen to our patient complain for 5 or 10 minutes before we can get them to take the drug we want them to take, but really to hear them and have some way of capturing what they're saying and trusting that they are providing valuable information potentially for their individual care. And then the trustworthiness piece is about making sure that our systems and structures and protocols are something that are inherently trustworthy for people who would otherwise not be that trusting, and then the trust will follow from that work. But I just feel like we are so often like looking out and trying to use cultural concordance or racial concordance with recruiters to sort of manufacture trust, but we can create the trustworthiness ourselves, and then people will participate.
Vic, give you the final word before we jump into Q&A.
Great. Gosh, I have so much to say about trust and some of these topics, but I'll just say one thing that's really, I think, is I'm hopeful about in the clinical trial space is seeing a framework from the FDA on diversity plans, and we believe the European Medicines Agency will follow suit shortly, and it's really given us a central focus. When the FDA says we really want you to demonstrate the representativeness of your trial population, we really want you to look into are there differences in how people respond in terms of safety or efficacy, and even to the point that your drug may not get approved until you can show that. And so that's really given us a common language and a common focus. So many people in my group are now looking at how do we set a good target? How do we know what this population really looks like? And how do we know when we've done a good job of actually reaching a good representation of who's going to most benefit from potentially benefit from this drug? So that's one thing I'm really encouraged about in the future.
It's awesome. All right, so we have a few minutes left for you guys to ask any questions of the panelists you want. Do we have any questions out from the audience? Any brave souls who want to go first? Comment is fine.
First of all, thank you for an incredible session. I really appreciate your time and energy. I think it's a really important point that community engaged research should be, it's long-term, it's committed, it should be compensated and funded from an institutional level from the idea inception, and that we don't come in when it's too late from the design, and that we can't serve our communities unless we start from the beginning with our communities, and that it's sustained. I mean, it is long-term work. So I just wanted to say that.
Hear, hear.
Thank you so much. I am a PhD student currently working on a project hoping to, work with Black and Brown communities explicitly, especially like as a Black woman. I find this incredibly important to increase diversity in our data that we're working with when thinking about tech dev and stats dev. So I'm wondering y'all's thoughts on consent forms, and I guess that the process of being the most transparent that you can be when working with communities that traditionally, for very good reason, do not trust scientific research.
Go ahead, Alex.
I can maybe start on that. So I work with Barbara Koenig, who's a bioethicist at UCSF, and she talks about how consent can't just be a transaction, a one-time deal where somebody signs a form and then we believe we have the right to do whatever we want with the data after that point. That's the model so far that we've been operating on. So I think there are a lot of very innovative ideas coming out of indigenous genomics groups. So the CARE principles, right? We operate on the FAIR principles typically: open data science, findable, accessible, interoperable, and reproducible, or was it reusable? But the CARE principles are about having collective benefits, having authority to control what happens to their data, responsibility to communities and to the promises that are made in developing those relationships, and that there's an element of ethics in what it is that we're doing. So if we're building our research on the FAIR principles, all we care about is getting somebody to sign something, and then we can go off and make all the, create all these ecosystems to do research on people's data, and they don't really need to be involved anymore. Versus the model where you treat it as an ongoing relationship and a negotiation where there's ability to revoke access to someone's data if their trust has been violated, for example. So I think there are federated systems and models out there that can be used. And I think there are lots of really great scholars who are writing about ways to do that. So we just need to connect the dots and start investing in projects that are operating on principles that are broader than just what we can do in research.
So as a PhD student, Barbara Koenig, Koenig, PubMed, she's an anthropologist and an ethicist, and this answer was absolutely correct, but that's where you can get the background.
Yes, well, since we're talking about trust, this is something I emphasize with my group every day. Your main job is to earn trust, along the lines of what Alex mentioned. And and what that means is we have to be completely transparent. We can't sugarcoat things. If a drug didn't work, it's so easy to say, oh, but maybe this, there's hope for the future. No, if it didn't work, just say it didn't work and don't sugarcoat it. And we had a good example of that recently, where we did an interim analysis. We found the active drug was no better than standard of care, and we stopped the trial and we told every patient, unfortunately, this didn't work and we're stopping right now. But if you're hiding something, people know it, and once you've lost trust, it's so hard to earn it back. And so this is something every day with our patients, with our doctors, with health plans we work with, whether it's, our regulatory agencies, that we have to make sure that's our main job every day, in my opinion.
Yeah. And let me just say something about trust as well. When you do genomics in a place like Africa, there's a history of abuse, misuse amongst black people, whether it's in the US, it's in Africa. And sometimes that is seeped into people's genes. There's a general mistrust. I remember when we first started, even communities, or not even communities, the academics, the researchers in Africa thought that we might be a front for big pharma in the US, right? Because there's a mistrust for big pharma in the US because of some of the practices that have happened in Africa from a clinical trial perspective and other ways. And it's really important that you get on the level, right, of the people you're talking to. It doesn't matter whether it's the community or, and they can't speak English, then you have to find a way to get down to that level, speak the language they speak, understand what their fears are. And I know that sometimes there's a prescriptive way for us to do some of these things, but those communities don't necessarily know those things. They want you to hear them. They want you sometimes to go out of the books and listen to their concerns and how do you allay their fears, right? Because nobody wants to be another case story, and And I think that when we talk about trust as well, there's a role for pharma and the life science and healthcare space to really own up to some of the mistakes that have been made. To your point, if we keep trying to whitewash over what has happened, you're just perpetuating a lack of trust. It's like, if you can't own up to it, how do you know that you're not going to do the same thing in the future? And so I think that trust is one of the most important things in this precision medicine space. If we're going to realize the future of precision medicine, then we have to build on trust, because that's only when we can get the feedback we need from the communities we need to understand what's happening to us as humans.
Very good. Are there any other burning questions? All right, so one last question for me. We're going to end this on a very positive note, right? What are you most excited about? And I just want a 15-second, just one-word, two-word response from each of you as we go into addressing this issue. Start with you, Dr. Hart. What are you most excited about?
I'm most excited about the inclusion of social determinants in our thinking about health and disease.
Alice.
Giving people the opportunity to self-identify using their own words and language.
Abasi.
I'm happy that we are all coming to the same table now, and thinking about how to solve these global problems. I think that before that hasn't been the case. But when everyone can come to the table, then there's hope for the future, for what we can all do together.
Perfect. Vic.
I would say a really increased focus on understanding the need to get data on diverse populations and understanding similarities and differences in what treatments work or are safe in diverse populations.
Excellent. Well, thank you to our distinguished panel. Round of applause, please. Thank you to all of you who attended. If you want their home addresses, phone numbers, social security numbers, we'll make all of that available to you at the break. All right, thank you.